So before I start, how many of you take care of pediatric patients? So a small number. One of the things that I just want to mention is that some of what I'm going to talk about, I believe, is applicable to adults as well. So some of the educational strategies that I'm going to leave you with, I think you will find of interest for your adult patients as well. So let's see if I can get this open. As Dan said, I'm now at the School of Nursing, but I have been involved in pediatric pain research for a long time. And I've seen I've been involved from the time that we were emphasizing pain management to the time when we started noticing opioid adverse events spinning out of control, and now we're seeing that pendulum swinging back. And so my work has really evolved to the point where I'm very interested in how do we educate and give our patients the best information that is available for them to be able to manage pain safely in the home setting when they're prescribed opioids. We know that opioid prescribing is going down, partially due to the laws, and I know Chad probably talked about it yesterday, because we are so keenly aware of the opioid problems, we're more hesitant to prescribe opioids. But in fact, opioids still will remain a mainstay of acute pain management for a time to come and maybe forever. And so it behooves us as practitioners to really think about when we prescribe these drugs, how do we get people to understand how to use them safely and effectively? And of course, that starts in pediatrics. We know that about 15%, the most recent data that we have says that about 15% of kids will receive an opioid prescription in a year's time. And that number goes up with adolescents. About 1 in 5 adolescents, and that's up to the age of 20, will get a prescription for an opioid. So kids start being exposed to opioids when they are young. The most recent data we have, again, we know that the prescribing rates are going down, but about 2.5 million kids are exposed to a prescribed opioid annually. And this graph just, again, shows that the highest prescription rate is among 12 to 17-year-olds when we're talking about kids under the age of 18. When most practitioners prescribe opioids or analgesics to kids, what we're really looking to achieve is adherent short-term use. But there are some negative trajectories or things that we think of as negative trajectories, and one of those is persistent opioid use. In kids, we know that about 5% of kids will go on to have what's considered persistent use, and that's considered a second or third opioid prescription in a 3-month period or at greater than 90 days over the time of the first prescription. The other negative trajectory, and one thing that we really want to avoid, is misuse. And I'm going to spend a little bit of time talking about misuse because this is something that we really want to prevent, not only in our adolescent patients or in our kids, but also in our adult patients. And we know that the rates of misuse is pretty high. Some other negative trajectories that happen after prescribing are therapeutic error. That rate tends to be fairly high in some pediatric populations, and this is because parents may not understand how to give their medications, and this happens, by the way, with lots of medications, not just opioids or analgesics. Misuse has been considered to be non-adherent use, and that means that the patient takes the drug in a way that was unintended for in the original prescription. That could be somebody keeps it in their cabinet and they take it 3 months from now for another pain or another type of pain, or they take a prescribed drug in a higher dose or a little bit more frequently than it was prescribed. That tends to happen a good deal of time in all of our patients, not just pediatrics. Non-medical use is taking someone else's medication. Borrowing medication happens a lot. This isn't just with opioids, it's also with stimulants, which the rate is really high. It can happen with Xanax and anxiolytics. And in the elderly population, it happens with just about every drug. My mom used to share most of her medications with her neighbors. And then lastly, there's abuse. That is taking a drug for an a non-prescribed outcome. So most of the people who misuse opioids will misuse it to get an effect like pain relief, whereas a smaller percentage will take the drug for to get high or to have a different effect. And then lastly, the other adverse outcomes that we're really concerned about now are overdose, which, as we know, the rates are fairly high, dependence and addiction, which I'll talk a little bit about. Fortunately, for most pediatric patients, most people that we prescribe opioids to, they adhere to the drug in a way that it was intended, and they take it for a short period of time, sometimes even shorter than we typically prescribe it for. But there are some kids who will go on to use the drug persistently. And I think that this is something that we need to really understand, because we don't want kids to use opioids persistently over time. And then the rates of misuse, a couple years ago or a few years ago when the data started coming out, the rates were actually fairly high. About 1 in 5 kids, especially by the age of 18 years or in 12th grade, about 1 in 5 kids were saying that they'd used a prescribed opioid in a way that was unintended, either borrowing somebody else's or using their own. Those rates are going down a little bit, thank goodness, but they're still pretty high. And a smaller amount will borrow someone else's medication. So this first part of my talk, I really want to talk about some of the risk factors, because I think if we understand the risk factors for bad outcomes, that we can better understand how to mitigate those risk factors. So for the first couple of things I want to talk about is who are the kids who go on to persistently use opioids? And by persistent use, I mean persistent prescribed use. That means that we're prescribing them multiple times over several months. The risk factors are things that they probably make sense. Number one, major surgery, primarily abdominal surgeries. Kids that have conditions that are typically associated with more chronic pain tend to use opioids more persistently after the initial prescription. As Eric said, kids have a lot of abdominal pain. Those are the kids when they present for surgery. Sometimes those are the kids that go on to persistently use an opioid. The other thing is kids who have a bad early pain course, and this is the same in adults, typically higher pain at the time of surgery or at the time of initial prescribing, those are the patients that go on to persistently use an opioid. And then lastly, if they have multiple procedures over time, again, that's not surprising. If you have a spine fusion and then you have to come back and have another spine fusion, you're going to get another prescription, so you're going to end up being exposed to opioids over time. The thing that's a little bit more concerning and something that we need to be aware of, this data just came out last year in JAMA Pediatrics, that showed that kids with any mental diagnosis, even one mental diagnosis, and that can be ADHD, for instance, those kids have a higher risk of persistent ongoing opioid use when they are prescribed an opioid. And if the more mental conditions they have, the higher the risk. And these data show that the highest risk is if they have a substance use disorder. These data are very similar in adults. Patients with substance use disorders or using substances typically will go on, or not typically, but have a higher risk of going on to have persistent use. I've been doing research for quite a while on adverse events after exposure to opioids in the hospital setting, and we know that the rates of adverse events are fairly high. People have a lot of side effects when they get opioids, but these data just came out last year that were of real interest, looking at how often do kids come back to the hospital, either the emergency room or are re-hospitalized after getting an opioid prescription, or fortunately a smaller amount going on to die. And they found that about 1 in 2,600 kids under the age of 20, and this was using Medicaid data from Tennessee, I believe, those kids will bounce back and have a serious enough adverse event to come back to the hospital. And the one thing that's really interesting to me in these data are that the vast majority were due to, the child's own prescription was implicated in the adverse event. And what this says to me is that we need to do a really good job with teaching parents about how to manage these medications a little bit better to prevent these adverse events. The other thing that I think is of real interest to those who take care of children is that there's a difference in these adverse event types based on age group. And not surprisingly, in the youngest age group, as you can see here, about 80% of the adverse events were related to therapeutic error. When you start moving to the adolescent population, self-harm and abuse becomes much higher. And we know that the rates of self-abuse or self-inflicted injury in the adolescent population has gone up, has skyrocketed in the last few years, and suicide attempts are really high. And so these are the kinds of risks that we need to be thinking about when we prescribe an opioid to these kinds of populations. These data are very similar. These data came from poison control data looking at opioid-related poisonings in kids under the age of 20. Very similarly, most of the adverse events or poisonings or accidental poisonings occurred in a home, in the home setting, meaning that the child was exposed to an opioid in a home. And a little over half of these were unintentional exposures, and again, a large number due to therapeutic error. And in the teenage population, many of the exposures were intentional. So I want to turn our attention just for a minute to misuse. The one thing about prescribing opioids to kids is we're concerned, obviously, about their adverse events or their immediate adverse events when we prescribe them opioids. But there's also a longer-term effect of opioid use in children. And some of the most recent data suggest that even with legitimate prescribed use, when a kid gets a prescription from practitioners for a legitimate reason, wisdom teeth, surgery, whatever, that there is a small increase in risk for them to misuse an opioid later, or them to report opioid misuse later. When I start talking about education, we think this has to do a lot with the initial exposure, how risky people think the medication is, and how beneficial they think a medication is. When kids misuse a medication, or they report misusing a medication during adolescence or childhood, their risk goes up even higher for later misuse. And so we want to stop the misuse trajectory when it starts, and we also want to think about how to prevent later misuse in children that we prescribe legitimately to. The other risks that we want to think about are that when kids use other substances, their risk for later misuse goes even higher. So kids who misuse an opioid and then also use other substances, their risk for later misuse is higher, and there have been some data showing that opioid dependence and substance use disorder or opioid use disorder later in adulthood can also be related to exposure during childhood. One of the things that, one of the data that came out from some of my colleagues in the School of Nursing show that the lower the age of initial opioid misuse, the more likely or the higher risk for later abuse. And so again, what these data suggest to me is that when we prescribe or expose kids to opioids at a younger age, we really need to emphasize the risks of misuse. Importantly, as a pain researcher, for me, one of the things that I always think about with kids, and I think a lot of what I've heard today really talks about the symptoms and symptom management that we're trying to get, that we're trying to help children and people reduce their symptoms is the motivation that kids have to misuse opioids in particular often is to self-medicate or self-manage symptoms. And what this tells me is that maybe we're not doing a good enough job helping kids manage their pain, manage their sleep, manage their anxiety. Because when you start looking at the motivation, and these are from national data, the main reason that kids misuse opioids, and again, that's taking their own medication, taking someone else's, borrowing it, is in order to manage pain. They're also trying to manage other symptoms, and a smaller percentage of those kids misuse the medication to get high. And that percentage goes up a little bit in college, but getting high is a less likely reason for them to misuse the medication. But even misuse for unprescribed pain relief, misusing a drug in a way that it wasn't intended, but in order to manage pain, increases the risk for opioid use disorder. So again, it's really important that we teach kids it's not appropriate to misuse medications. A really interesting article that I found as a pediatric practitioner. We know that parents influence their kids, but these data just came out, national data, showing that when parents, or particularly a mother, misuses or reports misuse of an opioid, their kid is at much higher risk of misusing opioids. And I'm doing a study right now where we are looking at parental use of medications and their treatment of their children. And we had a significant number of parents say that they misused opioids in the past. And primarily they misuse opioids to manage pain. So they keep the Vicodin in the cabinet to treat their pain at a later time. Those parents are often more likely to share with their teenager. Their teenager comes home, has some pain, here, take this Vicodin, it'll help your pain. And so when kids start seeing that kind of misuse or misusing of any medication, they are more likely to think it's okay, to think it's not risky, and then go on to misuse it. The other thing about these data that really sort of inform my work and also what I believe to be true is that when people have higher risk perceptions of the opioid or higher risk perceptions of misuse, they are less likely to misuse it. And so this is a really important target for us when we're teaching people how to use medications, is to target risk perception. We also found that a couple years ago we did a survey of community kids age 15 to 24. I call those emerging adults, and many of you are taking care of those kind of patients. So in the emerging adult population, these are kids that are now beginning to self-medicate themselves, and they're doing that without a whole lot of knowledge. And what we found was that we asked them a lot about their pain. How did they manage pain? Did they use medications in the past? And how many of them either borrowed or used a prescription in a way that it wasn't intended? And what we found was that when kids had a much higher risk perception of opioids and opioid misuse, their misuse behaviors went down. When the kids who misused drugs had much lower perceptions of risk. They thought it was okay, they thought it was safe, and they really wanted to just manage their symptoms. The other thing that we have found, and we found this persistently in our parent population as well as the adolescent population, is that just knowing the opioid risks, that opioids are addictive. By the way, about 90 to 94% of parents that I've surveyed know that opioids are addictive, even when used for pain management. That when they know that these drugs have side effects, it didn't lower their misuse behaviors or intentions. The only thing that really that was associated with lower risk was their risk perception. They knew it was a risk, and they knew it was risky, that it was dangerous. And so one of the things that we're looking at now is misuse in adolescence. And so other data have shown that that people who have perceived lower risk and previous use have a 9-fold increase of prescription opioid misuse. And this is the same as those who use marijuana, the same kind of risk perceptions. Kids who have a have a perception that marijuana use is high or that it's risky, they're going to be less likely to use marijuana. Same thing with sharing drugs, smoking, or texting and driving. So risk perceptions and behavior go hand in hand. I think that these data probably apply to adults as well, but it's certainly adolescence is the critical time when risk perceptions are forming. So the targets for primary prevention when we are prescribing opioids or any analgesic is therapeutic error for parents. We want to teach them how to give the drug safely. I'm not going to go into that a whole lot. We want them to understand or recognize the risks, but importantly, we want them to have the appropriate risk perception. And I don't know how many of you were prescribing or taking care of patients in the 90s, but we were telling patients in the 90s, oh, these drugs are really safe. Opioids are safe. They're not addictive. They're really safe. We didn't want to tell them a lot about the risks because we thought that they weren't going to use them to treat their kids' pain or to treat their pain. We now know that that's a really bad approach. What we want is for people to have a healthy risk recognition. And we want the same in adolescence. So the parental education targets. One of the things that we've found and other people have found is that parents are uncertain about the important risks. They know some of the risks, but they're uncertain about the important risks. They are a little bit uncertain about multimodal pain management, so they think that if they give the opioid, they really don't need to give Tylenol or ibuprofen because they're covering the pain. And they're uncertain about how to address important signals. So they know, for instance, one of the things that we were really interested in early on was over-sedation. Everybody knows that sedation is an adverse effect that's associated with an opioid. Every single patient that we surveyed knew that. But what they didn't know was how do you recognize what's too much sedation? And then what we started seeing was that kids were unfortunately dying in the home because their parents thought they were sleeping normally after surgery. The last thing that parents don't understand is how to the importance of supervising medications for children. And this doesn't only apply to opioids, but it applies to every medication in the house. So education on safe analgesic use is, at least for pain management, we need to emphasize the use of non-opioids and non-pharmacologic strategies. Parents are very, very willing to use non-pharmacologic strategies, and most kids that we've talked to and surveyed are already using lots of non-pharmacologic strategies. And so we need to emphasize the use of those. Using non-opioids after every kind of procedure is really important. And then when we do prescribe an opioid, we need to talk more specifically about how to safely administer them and when to stop using them. And one of the things that I think is really important is we need to create a social norm for all of our patients that, oh, most people only need these drugs for a couple of days after surgery. And so if we create a social norm, most people will stick with that because they want to meet that same target. We want to caution them regarding timing and dosing, and then nowadays, we do not recommend around-the-clock opioid dosing. We do recommend, at least for after acute pain experiences, around-the-clock non-pharmacologic dosing, but we definitely do not do around-the-clock opioid dosing anymore for acute pain. We need to teach parents how to recognize and respond to the most common and the most worrisome adverse effects. And I believe that this applies to every medication that we prescribe. If we are prescribing and a drug for hypertension, what's the most common adverse effect and what is the most worrisome thing that you should watch for, even if it's rare, and this is what you do. And the thing is that parents are already worried and uncertain about how to give medications, and people will already start managing their own medications based on side effects. So they'll lower the dose. They'll take more if they're not getting the effect. We need to make sure that we tell them, what's the risk if you take more of this medication? Because people will do it. We do have a lot of brochures out there. This one from Michigan Open sort of outlines for you some of the main things that we need to target. The one thing that I would say is that pamphlets and lists, they increase recognition of important things. Like when we hand a pamphlet to a patient with a list of adverse effects, They don't really address which ones of these adverse effects are important. So, you know, some of the advertisements that are on television that just rattle off all of the adverse effects that can happen, they don't really help us, do they? Something might jump out at us, well, I don't want to have nausea, but they don't tell us, well, how do I avoid nausea? Constipation obviously is the most common adverse effect of an opioid, but we don't necessarily prepare people. How do you prevent constipation, and what do you do if you have it? A lot of the kids who bounce back into the hospital or the emergency room come because of constipation, and they're having pain from their abdomen from constipation, not something else. And so we really need to help people understand that. And then, what's the riskiest thing that could happen? With an opioid, it's toxicity. What's the first sign of toxicity? It's oversedation. And that's what we need to tell people. When we start talking about respiratory depression, that's becomes sort of a later sign. We need to talk about oversedation. So again, when we give information about opioids, we need to enhance the risk perception. We have found that when we target and enhance risk perception, the important risk perceptions, we are able to get parents to give these drugs more judiciously. They use them, they give them at a time when it's not risky, and they avoid giving them at a time when it is more risky. Most of you know about the opioid consent in Michigan. I think that I just feel like this isn't very helpful when I see people going through this, because again, all it does is give the list of things that can happen. There may be a couple of things on here that people don't know, but most people already know these risks. What we really need to do is strategize and give people information that's that they can act on. And so what we've developed is, and I think that this might be helpful not only to parents and adolescents, but also to adults, is giving them common scenarios. This is something that could happen to you after surgery, and this is how you would deal with this and how to respond to this if it does happen. And so we call this scenario-tailored information. We're now testing this in kids. We've already tested this strategy in adults. And what we do is we give information that will heighten the risk perception. So for instance, oversedation, that's one of the things we wanted people to recognize. We tell them what it looks like. We give them the information, and we say, this is dangerous because when kids get oversedated, they can stop breathing and die. And as soon as we tell parents that, they recognize, oh my gosh, sedation is not necessarily a good thing, and when my kid's too sedated, I'm going to withhold this opioid. There's diversion prevention strategies. Again, getting people to get rid of their opioids in the home. How do we do that? We've provided lots of different routes to be able to do this. One way is just to decrease the prescribing, and now we don't have any leftovers. That's happening. But we also give them disposal methods or a disposal box. But how do we get people to actually use those? Well, again, what we've done some strategies to not only give them a tool to dispose of their opioid, but we also then enhance their risk perception. And what we found was that the tool alone was able to boost disposal or getting rid of leftover opioids, but giving them information that young kids have gotten into the medication and died, that when we told parents that, they were even more likely to get rid of the opioid. The other thing that I just want to talk about with my data is that when parents have misused an opioid in the past, that they are less likely to get rid of an opioid. And so this is something that's really important, because as pediatric practitioners, we often will assess the kids for their risk behaviors, but we don't necessarily assess parents. And as Eric said, parents and kids come together, and we really need to think about, well, if a parent believes it's not risky to keep this drug around or to share it, then they're more likely to teach that behavior to their kid, who then goes on to misuse the drug. So we really need to think about targeting parents as well as kids. So the one thing that I want to end with, and I'm going to speed this up a little bit, is what do we do with teenagers and emerging adults? There are lots of there's lots of thought out there that we need to teach teenagers about the risks of opioids and the risks, and I would say the risks of any medication, because again, kids are starting to manage their own symptoms. And there's two things to target here. One is knowledge and one is risk perception. This particular brochure came out of the NIH, and I think if you're interested, it's a particularly nice brochure because it talks about the risks in a way that should enhance risk perceptions. It gives information about how many kids misuse medications, but it uses terms that don't create what's called a social norm. If kids think that everybody is misusing a medication, like a stimulant, they think it's okay, they're going to do it. So what we need to create in them is a perception that very few of your peers are actually doing this, and it's really dangerous to do this. And so when we give them verbatim information about the percentage, they're going to say, oh, well, that's a lot of kids that are doing that, so I might as well do that too, or it's okay to do that. Whereas if we tell them that fewer patients are doing this or fewer people are doing this and it's really dangerous, they get a different kind of message. This particular brochure gives information like, these prescriptions have dangerous consequences. Are opioids addictive? Yes. And it talks about the deadly problems that can happen after opioids. Can you overdose from opioids? Yes. You don't want to say it's rare. Yes, you can. Because if you give them the statistics that less than 1 in 100 people die from this, they're thinking, oh, well, I have a 99%, do this particular behavior, and they survive. So what we need to do is just say, yes, this is possible. That's called gist information. It gives them the gist that this could happen, and it raises risk perception. So that's the kind of way that we should be giving information to teenagers. The other thing that I think is if you add images that at heightened risk, they've shown this with smoking and with other things, if you give them images, it may even heighten risk perceptions even more. We're doing some tests of our scenario-tailored strategies right now with adolescents, so we don't have any results. But one of the things that we want to see if we can do is increase misuse risk perceptions by telling them the risks of dependence. And again, not giving them verbatim statistics, but saying that this is what happens with dependence. The more you take a medication, the more likely you'll become dependent on it, and the less likely you'll be able to stop. And so we give them information that will increase their gist perceptions. The other thing that I want to talk about is that even though we are prescribing less opioids, death rates are going up. There's a lot of, I don't know if Chad, if you talked about this a little bit yesterday, but we know that decreasing prescriptions will decrease the exposure to prescribed opioids. But for some reason, the death rates are going up, and we think it's because people are getting more exposed to deadlier opioids, probably from the streets, could be because of fentanyl. And in fact, we know that even in adolescents, the death rate due to fentanyl has skyrocketed in 2017, whereas the death rate from prescription opioids is going down, as well as heroin. So one of the things that I think it's really important to do if you do take care of emerging adults or adolescents or even adults, that we talk about fake medications that are on the streets. I heard one mom who talked on NPR whose adolescent borrowed a Xanax, what he thought was a Xanax from somebody, took half of it to help himself sleep and died of a fentanyl overdose because the teen got Xanax that was laced with fentanyl. And so I think there may be some other strategies that we can do to enhance the risk perception of borrowing tablets from people on the streets. Interestingly, the data from Michigan show that of the, let's see, it was 1,000, more than 1,000 or more than half of the 2,000 opioid-related deaths in 2017 involved fentanyl. And in 2012, that was in 2017, in 2012, only 72 synthetic opioid deaths had occurred. So there's a lot of fake fentanyl out there, and I think this is something that we need to talk to teens about. This is a very busy slide that shows how to screen kids. There are screening tools out there to screen for risks in kids as well as adults. But I think as a practitioner, when we prescribe medications, it's just important to say, have you ever used, first of all, have you ever smoked? Do you ever drink, et cetera? But have you ever used a prescribed medication in a way that it wasn't meant to be used? That's a really important question to ask our patients. I would say ask it of adults as well, because if they have, there's a lot of education that could happen right there. And talk about the risks when you take somebody else's medication. We know that people with a history of substance use, as well as psychological disorders, are at increased risk for opioid misuse. And so just asking them a few of those questions, even in the absence of a screening tool, will enhance our ability to do some education at the time of prescribing. There are contracts out there to help people. I don't know how useful they've been. We've not seen a whole lot of data on how useful they are, but getting kids and parents to sign contracts to use their medication as prescribed is really important. We have one from the School of Nursing. And then looking ahead over the next few years, we're going to see a continued decrease in opioid prescribing. But one of the things that we want to be really sure that we're doing is still managing pain, because we know pain is a big motivator for misuse and self-management. I didn't talk about misusing non-opioids, but we do know that some teens and young adults have misused non-opioids. They've overdosed on acetaminophen. They can use NSAIDs in a way that they aren't intended. We probably need to enhance their risk perceptions, or at least knowledge about the risks of those medications as well. And then we must address the mental health and wellness needs. And I just want to leave you with this one slide. There was an interesting article in the New York Times the other day about Gen O, which is Generation Opioid. This is the fallout from the generation that we have, that we've created. There are over 500,000 kids that are now in foster care. A third of those are related to opioids or exposure to a parent who has a substance use disorder. We know that adverse childhood experiences predict poor health, substance use disorders, opioid use disorders, and later in life. So these are the kinds of things that we might be seeing in the next 20 years, and that we need to really think about taking care of these kids and helping them cope with the fallout of the opioid epidemic that we've had in the last few years. And that's all that I have to say. Sorry I talked so fast, but I was thinking the time was running away.